Hello, and welcome to our live stream on antidepressants. It's part of our celebration of Mental Health Awareness Month, and we're so glad you've taken the time to join us live or via recording. I'm Kara Gavin with the Michigan Medicine Department of Communication. Today, we hope to provide information to help you understand the current state of knowledge on medications used for depression, from the basic neuroscience to the latest clinical guidelines, and even things you might see advertised or talked about on the internet. We also want to talk about efforts to help individuals find an antidepressant that will work best for them and the questions that remain unanswered about how to go about that. And we'll talk about how antidepressants fit into the broader toolkit of ways to treat depression and keep symptoms at bay. A note for everyone watching, we may mention topics related to suicide and self-harm today, so if you would prefer to watch later, you can. And of course, if you or someone you know is in crisis, please call or text 988, the National Mental Health Crisis Hotline. We're so fortunate today to have three University of Michigan experts who can help us understand what we know and don't know about antidepressants and the broader topic of depression treatment. Two of our panelists are psychiatrists and members of our medical school faculty. They are Dr. Srijan Sen, the director of the Eisenberg Family Depression Center and a professor in the Michigan Neuroscience Institute and Department of Psychiatry, and Dr. Sagar Parikh, a professor in the Department of Psychiatry and the School of Public Health. Our third panelist, Dr. Amy Vandenberg, is an associate professor at the U of M College of Pharmacy and a clinical pharmacist at U of M Health, focusing on mental health care. Thank you, all three of us for joining, three of you for joining us, and thanks to the U of M Alumni Association for supporting this live stream. Before we start, a few housekeeping items for our audience. If you're watching this live, you can submit questions at any time, and we'll pick some to be asked during today's chat. Questions can be submitted by commenting on this video on whatever platform you're watching on, but please note that your name or your profile name will be visible to others participating. If you prefer a more anonymous option, you can send a private message to us via the Facebook direct message function on facebook.com/Michigan Medicine. We know that there may be many questions, so we'll likely combine some on the same topic. And please know that our experts cannot give specific advice for an individual situation you might be facing. If you can't stay for the whole chat or you want to share the recording with a friend, it will be available via the Michigan Medicine YouTube channel afterward. So I want to start with our questions and start with some history. We might think of antidepressants as a relatively recent thing, but could my experts here start us off by helping us understand how long humans have been trying to treat depression by taking herbs or pills or other strategies? Who'd like to tackle that?
I don't have an exact date for you, Kara, but we have records from ancient cultures going back, um, uh, centuries and millennia on different folks trying different plants and herbs and other interventions to help depression. I think the probably the modern era of antidepressant treatments dates back to the 50s, the 1950s or so, when other medications like tuberculosis medications were found to have some antidepressants effect, and that sort of kicked off development of medications from monoamine oxidase inhibitors and tricyclics to SSRIs in the 80s and some of the medications that we've developed. And we've made a lot of progress and added new medications to our armamentarium in the last 70 years. But certainly this has been something that people have been concerned about and working on for as long as we know. I don't know. Sure, sure. So, I think moving on from sort of the long history, I think a lot of as I talked about, there's been a growth in antidepressants that we have, and more people have been on antidepressants in recent years. I think one of the things that frustrate people is the trial and error nature antidepressants and if there's hope companies have been promoting tests for the genomics of depression and trying to find the medications that work. Maybe Dr. Vandenberg, could you tell us a little bit about what these tests are, what they're called, and who should use them, how they're covered, things like that?
Sure. So this has, been growing over the last few decades is the notion of pharmacogenomic testing, and psychiatry is one of the big areas where this is done. And it's basically testing genes that impact how our bodies process medications and in some cases how our bodies use medications. Most of the tests that are available for antidepressants are looking at really how our body processes medications, and they can be used to help us predict whether somebody may require a lower dose than usual or a higher dose than usual. We don't have a test at this point that says this is the medication that will be effective for this patient. Even before these tests were available, though, we kind of did genetic consideration, because for decades we've said, hey, have you had a family member with this similar condition? Have they been on a medication? Did it work for them? And that may be a medication that we would start with, because those shared genes, likely in addition to the ones that we're able to test for, may predict that somebody's going to do well on a medication. At this point, some insurance covers the testing, some insurance does not. Cash price ranges from around $300 to $500. There's been an uptick in the last decade of whether or not insurance will cover that testing. And so when might we consider it? Well, maybe 1 in 5 people will have some variability in a test that would impact an antidepressant medication, but again, it's not going to tell us which one to start. So we may consider it in somebody who has had adverse effects at low doses of multiple medications to see if we can help predict which one they would tolerate better, or in somebody who's tried multiple medications without benefit, just to make sure that we're not underdosing the medications, and maybe we need to either choose something different or get to a higher dose.
Thank you so much. And I'm so sorry. I had a power outage at my house for a couple of seconds there. Sorry, I had to jump off and jump back on again. Thank you for keeping going while I was off. So it sounds like you got into that question of the pharmacogenomic testing. And I think this idea of attitudes toward antidepressants. And Dr. Parikh, do you want to jump in on sort of what you encounter when people are talking about starting on an antidepressant or trying to continue on one?
Well, there's a lot of controversy around antidepressants, and the statements go both ways. Antidepressants are extremely commonly prescribed. They're also underprescribed. The reality is that antidepressants, number one, are not addictive, and that's one of the fears that sometimes people have. Secondly, just because something doesn't have a test to predict what medicine will work for you doesn't mean that there's no basis in considering it. We have lots of evidence around what works. A lot of the evidence comes from studies of groups of people, and this is where you make a jump or a leap, saying, okay, we tried this medicine on a large group of people who had depression, and a certain percentage did well. We can't predict who's going to do well one-on-one, but we can say from the evidence that there's pretty good proof that the medicine worked well, in this kind of group study. The commonest things that people say when they're asked about a medicine, about taking an antidepressant, is one thing that I've addressed it already, which is, is it addictive? The second is, of course, does it work? And what are the rates? So about 2/3 of people will benefit in some way from the first 1 or 2 antidepressants that are tried. So that leaves a sizable number, 1/3, who won't. And of the 1/3 who won't, maybe half of those will eventually find something within the medicine realm that does work. But again, there will be a significant number of people for whom antidepressants don't work.
Great. Anyone else want to jump in on that topic as well, of what patients are thinking maybe as they're being prescribed for the first time?
I think one of the things that is different about these medications versus things people may have taken for other conditions is that they do take a long time to work. And I think that's where some of the frustration comes in. So we're looking at 6, 8, 12 weeks to have maximum benefit. And it's not that at 8 weeks you wake up and the medicine finally worked, but it's that there's a slow incremental benefit over time, which is very different than, if I'm treating high blood pressure or treating pain or an infection, those things are going to work quickly. And so having that expectation that this isn't going to have an instant benefit, I think is really important up front for somebody who hasn't been on these before.
I think, that's certainly true for the majority of antidepressants, but we're really at a tipping point, I think, in our scientific development. We now have several medicines that work quickly. And, they tend to be, because they're newer and very expensive, they're not necessarily that accessible, but at least they give us a paradigm, a hope that we can treat depression within a week or two. And, a couple of the medicines that are currently widely available, one is, of course, ketamine in its various forms. And the second is a medicine that is FDA approved for postpartum depression right now, zuranolone. And the studies are ongoing to see how well that medicine works for regular depression. That medicine is, you take it like an antibiotic. You take it once a day for 2 weeks, and that's it. And often people benefit for 6 months or more from that. So these are paradigm shifts. And we're also seeing that in another form of brain stimulation known as TMS, or transcranial magnetic stimulation. Recent research has shown that you can have an intensive form of this treatment multiple times a day for 5 days, and then you can be in remission in less than a week. So there's hope for rapid treatments.
That's great. And I hope we can talk more about those in later on today. Dr. Sen, I wanted to ask you something about that you and I have talked about before. And that's this idea of the common phrase of chemical imbalance, right? That the idea of treating a depression is correcting a chemical imbalance. And there were even ads for antidepressants that use that phrase in the past. And but is that accurate from a neuroscience standpoint? And what's actually happening when someone has depression and what's happening in the brain, and what happens when they take an antidepressant and it works for them? How would be better think about it?
I think that's at best an oversimplification, and probably, well, less charitably, probably it's wrong. I think grew out of the history that we talked a little bit about, and the hope initially that depression is caused by sort of a discrete or a few discrete changes in the brain, and the medications work by reversing those changes. I think modern neuroscience has advanced dramatically with animal research and to some extent neuroimaging, and we understand the brain a lot better and have mapped the fly brain, lots of really impressive advances, but none of those sort of clear discrete changes that are common to people with depression and people without depression don't have emerged, and medications based on that haven't really emerged. We have hypotheses and some really promising hypotheses, and changes, but nothing like that could be termed accurately a chemical imbalance. I think what's true in psychiatry and true across medicine is that the evidence for whether we should take these medications or who should take them doesn't come from these biological studies understanding the mechanisms, but really comes from the clinical trials that we've touched on, and hopefully can talk more about. And that's certainly true for antidepressants. And Dr. Parikh mentioned some of the data on how many people respond, and how much better it is than placebo in different trials. And that's true for non-psychiatric types of medicine. We take statins not because we think we have a sense of how they stop cholesterol synthesis, but there's pretty good evidence that a lot of the effects of statins are not through that mechanism, but we take them because they reduce cholesterol and reduce rates of death. And GLP-1s, we know a little bit of how they work, but they do a lot that we don't understand, but they produce substantial weight loss, and again, probably reduce death. So it's in all of medicine, it should be the clinical trials that drive our choices about medications, and that's certainly true. So not fully understanding the biology underlying antidepressants shouldn't be a reason for not taking them.
Great. And actually, let's talk about those clinical trials. And Dr. Brake, you talked about them a little bit, but those trials lead to then the development of guidelines that guide physicians and psychologists and others who prescribe antidepressants or advise on other treatments. Maybe could you talk about sort of what the overall toolkit is that we have for depression, including things like talk therapy and exercise and sleep, light therapy, mindfulness, meditation, social interaction. All of these are tools, right, that people can use.
Well, I'm actually going to back up a little bit and address a little bit of the earlier question about a chemical imbalance. And I say this more as an educator. You know, we sometimes need what we might call an elevator pitch or a simple explanation to give somebody an idea of what's going on. So the notion of chemical imbalance came from, you know, like 19th century and early 20th century medicine, when we had some diseases like hypothyroidism, where your thyroid was low, and simply taking a thyroid pill would correct the imbalance. And so, and same thing with diabetes, you didn't have enough insulin, you could take insulin injections and so on. So the first wave of thinking about the brain was also maybe there's just a deficiency of one hormone or another, and you can correct it. And while it's true that there's no one straightforward deficiency, the fact that there are multiple chemical abnormalities associated with various psychiatric illnesses, that's ironclad. So I think, as a loose, very generous statement, are there chemical imbalances underlying psychiatric illnesses? I would say yes. They're just not simplistic, like, oh, I need more vitamin D or so on. Now, with respect to depression, because it's a very broad disease, we're fortunate in that we have many effective treatments. These treatments are organized into treatment guidelines that you referred to, and both clinicians and patients can have access to these guidelines, so they can say, you know, what are the various treatments and what might be helpful for me. Broadly speaking, for mild depression, we tend to classify depression in terms of severity. For mild depression, psychotherapy is clearly the first choice. Things that are what you might call lifestyle interventions, like exercise. You know, if you're not exercising, suddenly introducing exercise. There are other things that are also useful for mild depression, and they might work by themselves. For moderate depression, and moderate depression is you have a fair number of symptoms and it's starting to really interfere with your life, either good psychotherapy like cognitive behavior therapy, or antidepressant medications, or some other things. But one of those two would be the main treatments. The other things like exercise would be a great add-on, but they wouldn't work alone, you know, for that. And then for severe depression, where someone is really consumed by symptoms, maybe not able to go to work or school, they definitely will need some kind of biological treatment, whether it's medicine or a brain stimulation technique. And of course, psychotherapy will be helpful. And then the other things will also be useful, but as an add-on.
We had an audience question come in about effectiveness over time. You know, maybe someone has found an antidepressant that works for them, but do they need to worry that over time it's going to lose effectiveness at that dose? Will they need to keep going up in dose and hit a maximum? What kinds of things could you say about that? Any of you, if you'd like to take that on.
Well, I'll just start off by saying most people will be able to have a sustained response to an antidepressant for a long time. Now, we don't have good statistics to say if you've been on, you know, a particular antidepressant for 5 years, that 25% of the people will then stop having a response. We definitely see some people losing response, but I wouldn't say it's the majority.
Yeah, I think it's a pretty common question that comes up, and I think that I don't think they lose effectiveness over time. I think depression can be a relapsing illness, and so if symptoms come back, doesn't necessarily mean that the medication is ineffective. May mean that we need to increase the dose, add another medication while we get symptoms under control, or some other intervention. And so, you know, I like to use the analogy of high blood pressure. So some people will be stabilized on a single medicine high blood pressure for a long time and not need another medication. Some people may need the dose increased, or have other medications added over time. So I think looking at the circumstances of the symptoms coming back is really important in those decisions as well.
Thank you. Thank you both. I think we need to absolutely address a topic that might be difficult for some folks to think about, and that's suicide and suicide attempts or death by suicide and the interaction. What do we know about prevention of suicide, death, or attempts using antidepressants? And also, are there times when taking one, especially at the beginning, might be associated with an elevated risk? Who'd like to tackle that one?
Well, I could just start off by saying the information around, the first question, do antidepressants in any way worsen suicide? That's been really clouded by conflicting studies and even statements by the FDA. So what I would say now is for the typical adult, antidepressants do not induce suicidal thinking. For for adolescents and maybe very young adults, like 15 to 25, there may be some temporary worsening of symptoms, which may also express themselves in increased suicidal ideation. So I think it's fair to be cautious about using antidepressants. When I say cautious, I don't mean not use them. I'm just saying be aware of any potential risk in somebody who's very young. But in adults, if you look at population level data, that is, you look at an entire population, look at all the people on antidepressants, look at all the people who have depression and all the people who are on antidepressants, the epidemiological data shows reduced death rates in people with depression who are on antidepressants.
Great, thanks. Any Dr. Sander, Dr. Vandenberg, anything else to add on that? Great. And then we've had a question from the audience about, does taking an antidepressant perhaps address the depression, but or worsen depression? Sorry, the person's asking, does it worsen depression, but maybe help with anxiety? And we had started off this chat talking about, are there other conditions like bipolar disorder or anxiety or chronic pain that antidepressants can also address? So maybe could we talk a little bit about how this class of medications works with other conditions?
I think if you talk about anxiety, it's going to be similar to what we talked about with depression. We know how these medications, we know some of the mechanisms of these medications, but exactly how they treat anxiety is less clear. There's an overlap between anxiety and mood. I think one of the other things to think about with adverse effects of these medicines is sometimes there's an initial sort of bump in anxiety when they're first started. But if I'm using them to treat an underlying anxiety disorder as the primary use, I don't know of any evidence suggesting that it would worsen mood in that case. We generally would use the same medicine for both if somebody had both anxiety and depression. So it shouldn't worsen depression, but alleviate anxiety, to answer that question. If we're talking about chronic pain as the other thing you mentioned, the chemical imbalance that we've associated with depression and anxiety, it's the same chemicals that are involved in multiple systems in our body. Serotonin's involved in how our gut works. It's involved in pain. It's involved in mood, anxiety. Norepinephrine or adrenaline is also involved in pain transmission. And so the medicines that work for both depression and pain are targeting some of the same chemicals in our body, just in different areas. So serotonin and norepinephrine are directly involved in how pain is transmitted, especially neuropathic pain. So I think about pins and needles in my hands and feet. If I can adjust how those chemicals are working in those nerve tracts, I can help that specific type of pain. So it seems strange that they're used for multiple things, but they're actually targeting some similar chemicals in that regard.
Thank you so much. Let's talk more about some of the things that people who are maybe more skeptical might be thinking, or they're hearing things on the internet and not sure what to think. So, there might be claims out there that maybe antidepressants aren't better than a placebo, or that maybe children shouldn't take them under a certain age, or pregnant women shouldn't take them. And so I don't know if there Are there studies in animals or in people that can help us understand some of these claims that might be out there that people might have heard?
Sure. Yeah, we hear these claims a lot, and I think there's an element of truth to each of them, but also, ways that they're not correct. I think, um, as Dr. Parikh mentioned, a lot of our studies are on groups of people, and across the groups, antidepressants are moderately effective and generally well tolerated in terms of side effects. But there's a huge amount of individual variation and more variation for antidepressants than a lot of other treatments. For some people, the medications can be transformative and you know they improve sometimes quickly and their symptoms completely go away. Others don't respond at all. Others have debilitating side effects. And we're just sort of starting to understand why. And I think hopefully this is an area we'll make progress in. But I think this explains some of the different experiences. Some people experiencing worsening of mood, some people worsening anxiety, some other things, and that I think people extrapolate from experiences of their own or others to more broadly, and that causes some of the confusion. So I think getting to that, what we call, heterogeneity of response is important, and understanding one person's response won't be another. And where we are now is trying them is usually reasonable given the overall side effect profile, but knowing that your response could be really different than your neighbor's response and could be different than your response 5 years ago.
And so the answer is then, if you have been prescribed one, is to go back to the prescriber and express that you're experiencing something, correct?
Yes, yes.
Okay.
So working with your provider, keeping track of the good and bad, and as we've talked about some of the placebo response, for our current frontline medications, the delay in onset, other things make it really difficult to figure out how much of response, whether your response in some cases. So keeping good track of it is really important. I do think I wanted to also address sort of something we talked about, and I think hopefully we'll talk about stigma later, but um, part of it is that we view antidepressants, as you talked about, as part of a whole suite of interventions, including psychotherapy and lifestyle things like exercise and sleep, and they all. I think sometimes we make a distinction between medications and interventions like TMS and the other ones. But really, they all work through biology. The only way cognitive therapy works is by changing your brain, and exercise has a lot of the same changes in brain circuits and size of different brain regions that SSRIs do and that TMS does. So there isn't a clear distinction between biological and non-biological interventions. Everything we do affects our biology in somewhat different ways, and taking one is not, taking an antidepressant is not a sign that there's something wrong with your biology, and responding to that is no different than responding to exercise.
Thank you so much. That's great. And I think your research also talks about things like stress or irregular work hours and things like that also contribute to risk of or worsening of depression. So trying to address those things as well.
Yeah, yeah. I could take a second to just expand on that. Um, I think some of the stigma comes from people thinking that there is that taking an antidepressant or having depression means that there's something sort of genetically wrong or a defect that needs to be fixed. And especially the way we diagnose depression now, the vast majority of cases, we all have our genetic vulnerabilities, but are due to some stress or something, either chronic or acute that's been going on in your life relatively recently. And so as you alluded to, some of my work is with physicians, and when physicians start their training, their depression rates go up about fivefold. That's not because something genetically changes in them. It's because they go from not working much to working 80 hours a week. And so when they're struggling, antidepressants and cognitive therapy and other things like that help them. acutely, but from a sort of public health perspective, the important interventions are to work on those upstream factors, and in physicians, a lot of that is reducing hours and improving work conditions, but finding those things from a high level in other populations and things that affect us broadly, like some of the lifestyle factors that Dr. Parikh mentioned, social connection, sleep, and exercise is really important to do, and hopefully can help us reduce the number of people who actually get depressed, and help them get better when they do struggle.
Thank you so much. We've talked a lot about getting onto an antidepressant, or finding the one that works for you, or finding other things that work. Let's talk maybe about the other side of things. When is it safe to start cutting back or stopping completely? How do we do that safely? And what would happen if someone just stopped taking it all of a sudden? So Dr. Vandenberg, would you want to address some of this, or Dr. Parikh?
Sure. So I'll start with the last question, which is pretty simple. So a lot of the antidepressants, the SSRIs and SNRIs, stopped abruptly can cause a discontinuation syndrome. So that's everything from a recurrence or a rebound of depression and anxiety to almost flu-like symptoms, to especially with things like SNRIs, patients will report almost neuropathic type symptoms. I've heard it referred to as ZAPs before. And these symptoms aren't dangerous, but they're certainly uncomfortable. So one is, if somebody does want to come off an antidepressant, certainly talking to their providers to determine if it's safe to do so, if it's the right time, and it's something that should be done gradually to maximize the tolerability of it. Abruptly stopping these is really uncomfortable. If we're talking about when to stop, that's going to be very specific to the individual patient. If somebody who's had one episode of moderate depression that responded relatively quickly, and all these stressors that we talked about are somewhat under control, and they've been able to start exercising and doing some of these other things that are going to help with neuroplasticity and help with wellness, maybe we talk about, after a year of being symptoms being under control, we start tapering off. But if somebody has had 2 or 3 episodes, or they have a family history of recurrent depression, that maybe isn't the time where we want to start tapering off medications. And that may be a case where we say, look, this is just like as if you had high blood pressure or diabetes. This is a medicine that's going to keep your symptoms under control in the long term, and this isn't something that we're going to stop. If adverse effects, start coming up, or there's issues with it, we can talk about transitioning, but in those cases, we wouldn't talk about stopping them altogether.
Thank you so much, Dr. Parikh or Dr. Sen. Anything to add on that?
Well, I'm getting the sense from a lot of these questions that there are very specific pieces of knowledge that people ought to have if they're grappling with these larger questions. And so I just wanted to draw people's attention to the fact that across medicine, we're really emphasizing these days something called shared decision making. And that is that the patient, as an equal partner, not only, discusses and to some extent negotiates treatments, but there's an obligation on the person to know something. And it's not just like waiting for the pharmacist or the physician to dump all this information in a short clinical encounter. So there are 2 resources that I wanted to mention. First of all, Michigan has something called the Depression Toolkit. So this is something that you can Google and come to, just Google the Michigan Depression Toolkit. Over 300,000 people from around the world access that toolkit annually. And it has a whole bunch of resources, information, questions, and so on that can inform people about some of the issues that we've talked about today.
And we're going to put that link in the chat of every platform where this is streaming too.
Right. So the Michigan Depression Toolkit. And the second is that one organization that publishes guidelines is known as CANMAT, and they have a patient and family guide to depression treatment, which was a product of 7 people with lived experience of depression working with the CANMAT team to rewrite clinical guidelines that were meant for doctors into much more friendly versions that individuals can read and family members can read. And what we really advocate is, and in fact, in a clinical encounter, we make sure that we have everyone get a electronic copy of this so that they can have a more meaningful conversation with their treatment provider. And these kinds of documents, they don't only talk about medicines, they talk about all the treatments, they talk about how to monitor your symptoms, perhaps what digital tools you could even use to either to monitor your symptoms or potentially to give you a head start on some of the CBT or other psychotherapy principles. But my main point is you need to be an informed consumer, and this conversation may help provide some information, but these other resources are really critical as well.
Wonderful. And I've actually just put the link to that CanMat toolkit in the document that my colleague is using for links to put in the chat. So hopefully we'll get that link into those comments on the platforms that we're streaming on. Thank you. So I want to also address something that came in from the audience. And we talked about the genetic testing to try and determine maybe if there's a best or worst medication to start with. If someone had some of the earlier versions of the test done back in the late 20-teens, should they have it done again? Have the tests gotten better?
There's not drastic differences that have changed since 2017. There's a few more companies that are available, but largely what they're testing is the same thing now that they did in 2017. So we haven't advanced to the point that I think it's worth doing it again.
Great. We alluded to side effects earlier, but I also think we should talk about not only common side effects, but also drug interactions and other types of interactions that antidepressants can have. So Dr. Vandenberg, maybe you could start and others jump in of how do these medications interact with other things and also interact with the body in ways that cause side effects.
Sure. So there's interactions with prescribed medications, and that I could talk about hours, just that. So I think it's really important to, a couple of things with that. It's important to go to the same pharmacy if possible, so the pharmacist can see all the medications that you're taking and help assess that, but also let all your providers know not only all of the prescribed medications, but anything over the counter or supplements that you're taking, just so we can look at those potential interactions. A few things that I get a lot of questions on about interactions with these medications, though, is substances. And so I talk about nicotine, alcohol, and cannabis and what they can do. And it goes from sort of simple to more complex. So nicotine is fairly simple. Nicotine itself can worsen anxiety in some patients, help anxiety in some patients who have tobacco use disorder. But I'm really more worried about smoking. So smoking tobacco or regularly smoking cannabis can actually affect the levels of some medications, can decrease the levels, which would decrease the effectiveness. And if you stop doing those things, and so this is only smoking, it's not vaping, it's not using nicotine patches, the levels can fluctuate back up. So not only the substances, whether it's tobacco or cannabis, but how you're using them is important in what we expect with the medications. If I look at alcohol, it's a little bit more complicated, doesn't necessarily affect levels of most of the medications that we use. There's a few exceptions. But when we talked a little bit about neuroplasticity, but if using alcohol can cause fluctuations in anxiety, it can cause fluctuations in the same chemicals that we're trying to target to help improve neuroplasticity. So they may not affect levels, but chronic alcohol use, routine alcohol use can decrease the likelihood that an antidepressant is going to be able to work, whether it's for depression or anxiety. So trying to minimize use can help the likelihood that the medicine's going to work. Again, into cannabis, gets more complicated. Cannabis, the two compounds that we think about in it are CBD and THC, and both of those can affect how our liver breaks down medications. And in some cases, they compete with each other. One will increase our ability to break them down, and the other one will decrease. And so we don't really know what's happening with the medications as far as dosing and whether we need to increase or decrease the dose. We don't have blood levels of these medications that we can take to assess that. So there's that part of it. And then there's also effects of cannabis in the brain that are, again, competing with what antidepressants are doing. So my general recommendation is if you've tried a few antidepressants, they don't seem to be doing the trick, symptoms aren't getting better, and the factor that we haven't changed is cannabis use, let's try to pull that out of the picture and see if the antidepressants may be more effective. If not, then we can look at other things. But there's some studies showing that while the cannabis can help symptoms in the acute phase that actually can worsen the course of depression over time. So, and it's very patient specific how folks respond to it.
Thank you so much. That was fantastic. And similarly with side effects, if folks are experiencing again, this idea of shared decision making and reporting those to your provider and making sure that the pharmacist or the physician or the psychologist or the nurse practitioner or the physician assistant or someone knows what you're experiencing, right?
Right.
So, we've talked a lot about what we have and what we can do. Dr. Parikh, we got a question that I think will be dear to your heart, which is, what are your thoughts on TMS therapy? And maybe you can also go into other types of neurointervention as well.
So briefly, TMS, or transcranial magnetic stimulation, is a technology that's been around as a treatment for depression, officially FDA approved since 2008. And basically, it's a lot like getting your teeth cleaned. All right, you go and you sit in this big fancy chair and you get a device that is about the size of a cell phone, and it's placed at a particular location over your head. And the old-fashioned, or still the most common form of TMS, you sit there in this dentist chair with this device, and it's having a rapidly alternating magnetic field, which to you feels a little bit like sandpaper being rubbed on your head. Now, that sounds painful, and maybe the first time it's a little bit painful, but you quickly get used to it. You have this treatment, you're sitting in this chair for 40 minutes, and this device is flicking on and off, and you have to do that daily for 4 to 6 weeks. So it's a tremendous time commitment. It's financially fairly expensive, but it works, and it works better than a standard antidepressant pill. And what to me is more exciting is the field is beginning to fine tune that. So the approach that was developed in 2008, it's reasonably good, but there have been lots of other studies that said, where should you put the magnet? What is the frequency that you use of the alternation of the current? And can you do it more than one time in a day, and so on? And so the two dramatic things that have happened with transcranial magnetic stimulation are that there's a fast form of it called theta burst, which you only have to have that treatment for 4 minutes. And the first way it was used is still every day for 4 to 6 weeks, but just for 4 minutes. And we used to joke, and this is true in some TMS clinics, your spouse drops you off, does not have to find parking, but just circles around the building a couple of times, and you go in, you have your 4-minute treatment, and you're out. So
is that covered by insurance? Of course, the $1 million question for most people.
Most insurance will cover TMS because it is an FDA approved treatment. And the latest iteration, there was one big splash from a Stanford variation of this, but now there are some competitors, but the Stanford variation is known as SAINT therapy, and they use the rapid form of TMS, and they have a particular way of targeting which area of the brain that they put the stimulation on, and they do it for 10 times a day for 5 days, and that's it, and that's really effective. So I think we're seeing lots and lots of opportunity to try these other techniques. Now, the newest forms of TMS, of course, the insurance industry has not caught up with yet, and so on. But I think it's illustrating that there's a lot of hope there. And, two final things about TMS. One is nothing's floating around in your system, right? You're not taking a pill or anything like that. So there are side effects, while maybe mild side effects while you're sitting there with the machine or whatever. But when you go home, unless you're tired or you have a little bit of a headache, basically you don't have side effects. And the second thing about these treatments is that the way they're working, it's a very different mechanism as far as we understand it than traditional medicines. So if traditional medicines haven't worked, then because this is working through a different mechanism, it really gives you hope that, well, that old standard way of boosting serotonin or whatever wasn't working for me, but maybe this other approach will.
So this is something people can talk to their provider about. Is it maybe after trying a couple of antidepressants, which is probably easier to get
that would be necessary
from your insurance? You basically have to not have things work, be able to be able to get coverage for
That's
TMS.
correct.
Okay.
That's correct.
Okay. I just want to make that very clear. Great. Well, that's exciting and on the horizon. Maybe let's talk more about the future in general. So Dr. Sen, maybe, let's start off with you on what don't we have in our toolkit of treating depression, and what kinds of research do we need more of?
Yeah, thanks. That's a great question. And I think we definitely need more tools like the exciting advances in TMS and things deriving from ketamine and maybe psychedelics and new things that we haven't even thought about. I think where we are now, I think sort of building on what Dr. Parikh said, that there are some people who SSRIs and sort of first line medications don't work, and other ones that they do work for, and the same with our therapies, and the same with TMS and ECT. I think because of that sort of reality, a lot of people cycle through different types of treatments before finding the ones that work for them. I think where we have a chance to make real progress, and some things we're working on at U of M, is to try to find if we could figure out earlier on which treatment people will work for, which of the sort of dozen or so really reasonably good interventions we have will work for you specifically. And that's been a question for a long time, but there's hope that some of the new tools that we have from sort of more advanced genomics and the mobile technology and how you're sleeping and exercising and social interactions and other things can really help us put together a picture of who you are and what type of patient you are in terms of the response. So I'm hopeful in the next few years we'll make a good amount of progress on that and be able to predict in a way. And then I think another that hopefully will help. I think and I think both Dr. Vandenberg and Dr. Parikh mentioned this, but sort of the delay that our first line antidepressants have now in how long they work is frustrating, and also can help confound our understanding of whether it's working or how it's working. So getting more things in the realm of ketamine and others that work much more quickly would be a great help into sort of the toolkit that we have. So and again, a place where hopefully we're making progress.
Thank you. Great. And we actually had a question from someone who said they'd had some genetic testing done, one of those commercial tests not related to mental health medication choices, but just to know their genome. Is there a future where you think someone could take the results from a commercial genetic test and bring it to a place like U of M and say, here's my genome, what should I be taking? And that kind of thing? Is that too futuristic to think about?
No, I think it's definitely possible. I think like Dr. Vandenberg talked about, a lot of our current ones work on how you metabolize medications and how much the dose you want and how it might interact with other ones. A lot of there's a clear genetic vulnerability to depression, anxiety, all most diseases, and certainly our common psychiatric ones, probably 30 to 45% of our risk is genomic. But a lot of that comes through vulnerabilities to different things. Some people are vulnerable to not having enough social interaction. Others are vulnerable to not getting enough sleep at the right time, or their sleep being misaligned with their schedule, exercise, so there's been progress in understanding that as our genomics has advanced pretty dramatically in the last 10 years in the volume and the scope of our genomics. So there's research showing that we can start to identify some of these different vulnerabilities and maybe apply it to which treatment works. We're not there yet that it's a standard part of how we approach patients, but hopefully we will be, and the genomics can help in guiding that way, not just sort of in how you're processing the medications.
Right. And of course, if we have all the treatments in the world, but people aren't willing to take them because of stigma, or they can't access them because of insurance or government program restrictions or whatever, that we can't do things for people that would be possible if they had access. So that's another kind of research, right, on access to care and coverage of care and cost of care. That's important. So I think we're getting toward the end of our time. So maybe I'll ask
Or
each
can
of
I
you,
just,
are there
can I
things?
clarify something?
Yeah, please,
I just want to
please,
clarify.
of course.
Currently, what something like 23andMe tests for would not be, we wouldn't be able to make decisions based on medications with that. I just wanted to address like that specific question. That may be something that's in the future, but if you've done those commercially available sort of personal tests, they don't really have clinical information for decisions, like the ones that would be ordered by a provider. Yep.
Great. Excellent. So, Dr. Vandenberg, since you were already unmuted, if you wanted to give us any closing remarks or thoughts that you have, or things we didn't touch on that you want to make sure we leave people with.
Yeah, I think so. I like to end on things that help the medications work. So I talked about some of the substances that can prevent them from working, and we've touched on this a little bit, but I think, thinking of managing medications as a multi-pronged process. So we have medications, we have things like TMS, we have things like ECT, but when we're looking at the impact on the brain, I think Dr. Sen had mentioned this before, the impact of exercise and socialization and diet changes and nature exposure and all of these other things end up having the same result. And so making sure that even if we find these things that work quickly, and have success with these things that work quickly, making sure that we're still addressing things like stress management, mindfulness, getting some sort of either socialization or physical exercise. And so whatever somebody is able to do, working with them on what else they can add to their armamentarium to help their symptoms stay stable over time, I think is really important. I think it's just like doing physical therapy after surgery. Surgery can fix things, but you have to do physical therapy to get that flexibility and strength back.
Great analogy. Dr. Parikh, would you like to go next with closing thoughts or other things we haven't touched on?
Well, we've alluded to things like stigma, and, we've also talked about the fact that there are so many treatments. So the one thing that we often do is we encourage people to get a second opinion, but not from a clinician, but from a person with lived experience of depression. And so we recommend a number of advocacy groups like the Depression and Bipolar Support Alliance, or DBSA. There are a number of these organizations which are, founded and run by individuals and family members with mood disorders, and they offer information. They also offer support groups and opinions. So, if you're not sure what your clinician is telling you, that's fine. You read, you watch some YouTube videos, you talk to your clinicians, but then talk to some people who have lived through that illness and put all that together. And so I often say, get a second opinion, but from one of these support groups.
Thank you so much. Dr. Sen, you get the last word.
Yeah, I think my colleagues said I completely agree and talked about the really important things. I think building off what they said, I think uh, you know, like Dr. Preek talked about a while ago, this is really shared decision making, and that's both a gift, but also an obligation, and learning about yourself in the ways that Dr. Vandenberg talked about, which, none of us have time to do all the lifestyle interventions about sleeping perfectly and eating fancy meals and socialize, that figuring out what's important for you and really emphasizing and prioritizing that. And then as you get new treatments, medications, really finding ways to assess how they're working, whether they're working, we mentioned some ways of tracking your mood and some of the toolkits we have, and maybe tracking your sleep and how much your life is changing in different ways. So you're really informed to make decisions with your provider on whether to change, whether to continue, and the different options available, and figuring out how you specifically are responding. And I think that can help really get to a good state faster than sometimes we do.
Thank you so much. Thanks all three of you for joining us. Thank you to our audience and my colleagues behind the scenes. And thank you for watching. We'd love to hear feedback, whether you comment on the live stream or send us a direct message on Facebook. And we also will put a link on all of our platforms where you can sign up to get on our email list to receive more mental health information from U of M. And we hope that if you've gotten value from this live stream or this recording, that you'll share it with others as well. Thank you so much for watching.